We're now recording. I'm delighted to welcome Florian Walter to this interview. He's going to talk about his research, which I find completely fascinating. Not being somebody familiar with epidemiology, I've learned so much from this man. So enjoy. Florian, can I just ask you to introduce yourself? Just tell us a little bit about what your current role is, first of all.
Yeah, hi Laura. Yeah, I'm Florian. I'm a lecturer in adult nursing, and before that, I worked at university as a research associate over in the Division for Psychology and Mental Health.
Thank you. Thanks very much. So the project you're going to talk about today, which will be linked in the next to the link to the video, you'll find a link to Florian's paper. Can you tell us a little bit about how you came up with the research question in the first place, please?
Yeah, sure. So the research question is basically looking at people who have been discharged from psychiatric inpatient services and what happens to them after discharge in terms of suicide, homicide, all-cause mortality, different types of method of suicide and things like that. And this paper that's linked is a paper out of in a series of 3 publications which all deal with the same topic and use the same data set. So we basically know from previous literature that those who have been diagnosed with a mental health disorder are at elevated risk for quite a set of adverse outcomes. So that is suicide, self-harm, accidental death, and many of these things. But what we don't know is how is the risk in those who have been discharged from psychiatric units. So those are obviously the more severe cases, those who require inpatient treatment. And previous literature has only looked at usually like one of those outcomes in one cohort. So for example, you would have a study looking at suicide in mental health patients or violent offending. But what we don't know is how these risks compare to each other, because when you have them done in different cohorts, it's very difficult to compare the risks to each other due to the differences in study designs, study cohort, methodology, settings, and all these things. So the idea was basically for us to take one big cohort and look at many outcomes in one, so that we could then actually compare the risk, for example, violent perpetration versus violent victimization. So which risk is actually higher? And that was basically the underlying idea for all of the papers in the series of this project.
Okay, so my understanding is that even though data had been collected on different elements of those data were what we call heterogeneous. So you couldn't compare, you couldn't kind of merge them to see whether there was kind of links between those different factors. So that's why you did such a big study. And that's why you looked at all those different outcomes. Is that right?
Yeah, that's right. Because when we are thinking of, let's say, a study done in America, for example, looking at violent offending, that would be very much different from a study on violent offending done in the psychiatric population in the UK or the Netherlands or in Germany, where you have underlying differences in the healthcare system, in access to means of violent offending and things like that. So it's very difficult to compare across countries, but also studies sometimes only restricted to a certain diagnosis, like schizophrenic patients or those with mood disorders, for example. And then comparing the risk across diagnosis is very difficult as well. So that's why we decided we use one big cohort and basically do all the analysis on the same group of people. Then we don't have these differences.
Yeah, so that kind of brings me to the next question, really, which is how on earth did you do that? How did you design a study that could address those issues across a big cohort?
Yeah, so I think what the big difference is that we didn't really collect any data ourselves. So what we did is we used what's called the population register data in Denmark. So when you're born in Denmark, you get a unique identifier number, and you use that to go to your GP, to go to hospital, when you have interaction with the police, any of these things. And you use this number, and you can basically link across different registers. So in Denmark, you have a lot of registers. They have a cause of death register, the hospital register, the criminal register, and all these things. So where data is stored, it's stored for administrative purposes, not for research purposes. But we could basically use the ID numbers and track people across these registers and across their lifespan. So we looked at all those, basically everyone in Denmark born between 1967 and 2000. Basically looked at everyone born and followed them up basically until they had the event of interest, or until the end of the study period, or until they left the country, or things like that, or until they died. And then we're basically able to build one big cohort study and follow people up across their life, basically. So we looked at those who were discharged and compared them to 25 comparison subjects matched on age and gender who had not had an admission. And then we could follow both groups up over time and see what happens to them. So we were lucky that we didn't have to collect like over 1 million people and collect the data ourselves. So we used already existing data, which comes with its own advantages and disadvantages, of course.
Could you tell us a little bit about the advantages and disadvantages of that?
Yeah, so the advantage is, of course, that it's a very complete data set. Because in Denmark, they're very good with these registers. So we have a very complete register of things. So we talk about like way over 95% completeness for most of those registers. So it's very easy. It's very cheap to do as well. So the amount of data that we get, you would never be able to collect this by hand yourself, because you wouldn't be able to go and collect several 100,000 or millions of people's data. So that's not possible. Obviously, the big disadvantage is that we are very limited in the information that we have. So we have information, we have certain clinical information on them, but for example, we wouldn't know the details of the treatment that they've received and things like that. So the number of the information that we have is very limited, but we have a very big data set. So it's a trade-off. What you get in epidemiological research generally, you have to choose between a large size of your cohort and a lot of information. You can't have both. You can't have over 1 million people and get really detailed information on it. And obviously, because like I said, the data is collected for admin purposes rather than research. It is not very clinical, the data. Even in the hospital registers, we use the basic information, basically, if that makes sense.
That makes sense. That makes sense. So for those of us who are not statistical wizards, can you tell us a little bit about how you went about analysing that enormous data set?
Yeah, so we basically used, we created two groups. So one group was those who have been discharged from a psychiatric inpatient unit. And then we had the comparison group, which were per discharged person, we used 25 people from what you would call the general population who did not have psychiatric admission. And we matched them on age and gender. So they were the same age and the same gender than the person who has been discharged. And then we used the index date, which is the date they were discharged. And we followed both groups up, and then we could compare what happened to them. And then we did something called Cox regression analysis, where you get a relative risk. So we would relative risk of 5, for example, would mean that the discharge group has 5 times higher risk than the comparison group. A relative risk of 1 would be no difference. And we also calculated something called the cumulative incidence, which is basically your risk of experiencing one of those outcomes in a 10-year period. So it's a percentage, for example, like 10% risk. And then we could compare those as well to see which group has a higher risk.
That's really helpful. That definitely makes sense of the sort of numbers that the students will see in the paper. I'll perhaps put a link in for them to find out a little bit more about what a Cox regression analysis is, if they want to kind of find out what's actually done if you're analysing data in that way. I'm really interested in what you found.
Yeah, so when basically it is what we found is what you would expect in a way. So we found that those who have been discharged from psychiatric inpatient unit have higher risk, absolute and relative, for all outcomes compared to those who have never been in psychiatric. What I have to say though is when we are saying the comparison group, that does not mean that these people will never have been in a psychiatric unit. They will have further down the line could have had an admission, but you can't condition on future events. Otherwise you would get a biased sample. So when I say general population, they are not necessarily healthy population because they could have mental health issues not treated in inpatient units. So I just want to point that out because they are not necessarily mentally healthy people. But yeah, so, and what we see in terms of relative risk is that the relative risk, so the risk difference between the discharge group and the general population is really, really high within the first 3 months for 3 of those outcomes, which would accidental death, non-fatal self-harm, and all-cause mortality, suicide, and accidental death. So these things would be where you see a big increase in the first 3 months, and then it kind of goes down over time, but stays elevated. But you see like this big chunk and this big risk elevation in the time directly following discharge. For the other outcomes, the risk stays elevated but fairly constant over time. So there doesn't seem to be this discharge effect, for example, for violent perpetration. You wouldn't see this massive increase in risk right after discharge. So we see two patterns: this elevated increase after discharge and this more constant risk elevation that stays the same. So what we could think that it means is for suicide, for example, there's like this shock of being back into the community and being discharged, being away from the safe area of a hospital where you have no access to means of suicide, for example, or for accidental deaths as well. You can't jump in front of a bus when you are in psychiatric unit. Whereas for things like violence, we believe that it has probably to do with you being discharged back into environment, you having the same friends and social environment. It's not so much a shock factor, but more related to probably the environment that you live in and the people you interact with that keeps your risk constantly high, and it doesn't really change. If you would look at different data from the UK as well, you would actually see that for things like suicide and self-harm, the risk elevation is higher the closer you get to the discharge date. So if you look at the first 7 days, that would even be higher than the first 3 months. But we don't have that amount of data in this study, so we didn't break it down any further.
It's an interesting finding, that kind of initial peak. I know we've spoken in the past about the kind of implications for services, for practice. I just wondered if you could just really briefly tell us kind of why it was important, whether it did or will hopefully bring about any changes in services.
Yeah, that's a good question, because I'm not sure if there will be any changes to services based on this. Realistically, so the NICE guidelines, for example, require people who have been discharged from psychiatric inpatient unit to have follow-up appointments with their GP or another practitioner. I think something like within a week or so, or 2 weeks, something like that, which is for a lot of people too late. So what we point out is that it is important for people to have support in place before they leave the inpatient unit, so that when they are out in the community, they have access to services straight away, rather than having to wait a month. Or, I mean, I don't know what the wait times at the moment would be, but if you would wait a month, then it might be too late for some people. Also, what we pointed out in a paper is that the absolute risk of violent perpetration is higher than for being a victim of violence, but the underlying number is still very low. So we wanted to kind of make sure that this paper doesn't get used as a reason to say that psychiatric patients are very dangerous because they have a higher absolute risk of these events. So I think when you look at the breakdown of diagnosis as well, we have shown that those with psychoactive substance abuse disorders have the highest risk for most of these outcomes. So what we propose is making sure that people are being offered substance misuse treatment while they are still in an inpatient unit to reduce the risk post-discharge. So rather than, again, having to wait and maybe people not engaging anymore with services once they have been in the community for a month or however long the waiting times are, we propose for a lot of these measures to be in place while they're still in a psychiatric unit. I know it's very challenging given the pressure that the NHS is under. But if we want to reduce some of these numbers and reduce the risk of people, which puts a burden not only on them, but also on the healthcare system due to subsequent readmissions or treatment that might be required, I think it is worth investing in these interventions early on rather than just letting them go until someone might not engage with them anymore.
Yeah, for sure. So almost like a prehabilitation approach before discharge is it's the obvious kind of conclusion to draw, isn't it?
Yeah, exactly. Yeah.
Thank you so much for your time. It's very much appreciated. If anybody has listened to this and wants to kind of read the paper, presumably it's okay for people to email you with questions about it.
Definitely. Yeah, feel free to get in touch.
Yeah, and you'll meet Florian in any case on the course. So I'd just like to take this opportunity to thank you so much for your time. And it's just, I find it a really interesting study, being sort of firmly grounded in qualitative world. It's been a really good exercise for me to understand that, you don't get necessarily the depth that you might do if you're kind of interviewing people about what it's like being discharged, but you get these whole population pictures that give clear patterns, and that those patterns can be drawn upon in how we think about our practice. So thank you so much for your time. Very much appreciated. Bye.
Thank you.